Hello, I'm Dr. John Kruse, and welcome to this week's Question and Answer Hour, where I'll try to address questions about the videos I released just this past week, or re-recorded and released, also about more general ADHD questions, and even more broadly, mental health issues in general. As usual, I will start with the 1 or 2 minute overview of the only one new, or actually it's a re-recorded video from a year and a half ago, and that was on bilingualism and ADHD. So traditionally, for most of the last century, the belief, at least in America, and yes, that may not be how the rest of the world viewed it, at least in America and in American educational circles, bilingualism was thought to be a disadvantage, that it would confuse children's brains, that it would overwhelm them. And there is some evidence that if you're learning two languages simultaneously, both vocabulary and grammar, you may be slower to pick up on in the first few years. In the last 20 or so years, the field has changed almost dramatically differently, so that the claim is learning a second language enriches pathways in the brain, so it makes your thinking more flexible, more resistant, more adaptable, more creative. And there is some evidence, probably the strongest through dementia studies, that having a second language does provide some cognitive reserve. So the evidence is that your brain has to be substantially more deteriorated at a physical level to reach the same levels of dysfunction as a monolingual brain does. So there is good evidence that it provides some cognitive reserve, as it were. The evidence for whether it's a barrier or a help with ADHD, whether it helps to train your executive functions or whether it helps to tax and fatigue your executive functions, there's a little bit of data on either side, and the research is complicated or contaminated by poor consistency in how we define multilingualism, and specifically which cognitive or executive function tests were studied. So that's what I have to present there. I do have one question that came up just in clinical practice the other day. So I'm working with a couple. They are both multilingual. One of them's native language is English, and they both have some proficiency in French, Portuguese, Spanish. One is French as his native language. Anyway, their observation, one person has ADHD, the other doesn't. The person without ADHD they both pick up languages fairly quickly, but the English speaker actually picks them up particularly quickly and, particularly speaks with almost no American accent. Whereas the other speaker who has substantial ADHD can understand the gist of what's been said and convey some of it, but has a very heavy accent. And their observation feeling was that the ADHD actually had a role in explaining this. So their reasoning is that because of sort of the haste and the nonlinearity and jumping around, that just getting the gist of things was good enough for the person with ADHD, and he didn't need to work or focus or concentrate on the accent or getting that right. So I'm throwing it out there for those of you who are multilingual and or have ADHD or know it in their partners. Is there any observation or feeling among you that yes, it may be easier, yes, it may be beneficial to pick up a second language, but that having ADHD make it harder to adopt a naturalistic accent? I know there's a whole body of research suggesting that the earlier you get a language in, particularly prepubertal, you are more likely to speak with sound like a native speaker rather than someone from a different language. So that's one of my questions, and I see there's already some good questions. I did want to turn to a topic that Philip asked at the very end of last week's session, and I didn't have time for. And he was asking me to comment on the differences between the ICD-11 which is the World Health Organization International Classification of Disease system for identifying ADHD, and comparing it to DSM-5, which is the Diagnostic Statistical Manual of the American Psychiatric Association, which is the standard in many parts of the world, not just in America, but is also clearly the standard used more consistently in research. And the two approaches have a huge amount of similarity. So fundamentally, they are based on a group of, in the DSM, it's 9 symptoms of inattentiveness and 9 symptoms of hyperactivity / impulsivity. In the in the IDC-11, there's 10 or 11 symptoms clustered in these two groups, so that the same overall structure is largely the same. The DSM, again, so that the ICD-11 splits off a couple of these symptom clusters. So the attention to detail and making careless mistakes is sort of split into 2 different categories. And the forgetfulness in daily activities is also split into forgetfulness in daily activities, and separating that out from difficulty remembering to complete tasks. There's also, I'd say, daydreaming is the only thing that's a little more explicitly included in ICD-11. And so strikingly, neither of them mention issues with emotional regulation or dysregulation. Neither of them mention explicit time management issues. So there's noticeable gaps that are similar between the two of them. But the more large-scale difference is that the DSM rigorously says for adults you had to have 5 symptoms, and for kids you have to have 6 of these symptoms, whereas the ICD diagnoses does not designate any specific cutoff. So it's much more, in the end, subjective and up to the individual examiner to determine, although you could argue that there can be a fair amount of subjectivity in deciding what is excessive for one's age and social group. I mean, some of these actually could be quantified and actually measured. We don't do that in actual practice very often. And some would argue that the ICD diagnoses is maybe more prominently used by public health organizations, by governments and others to assess the degree of certain types of issues or problems in their population, and that this more flexible framework for definition is better suited. And the DSM, is maybe more our best research tool in terms of more precisely defining what is ADHD and where the cutoff is. And now we have a vast body of tens of thousands of research products which have come to conclusions and results using that as a definition. So I think, again, moving forward, both of them are going to be changing, and my belief is going to be more a research diagnostic domain criteria. I'm mangling the term there, the RDC put forth, which is trying to link more, I would say, modules of the brain, how the brain functions and what can go wrong with those functions, and defining those as problem areas rather than maybe overarching syndromes like depression and ADHD and schizophrenia. So that, I hope, is my answer there. So I do see there's some questions that have come up. So G asks, can the stimulation of the areas adjacent or close to the prefrontal cortex help to improve the function of the prefrontal cortex too? Like, for example, if stimulating the right premotor cortex helps improve precortical function. So I'll say a couple things there. One is I am not aware of any specific evidence that is testing whether we are specifically activating and adjacent to the prefrontal cortex, how much spillover impact it's having on executive function, prefrontal cortex function. So I don't think we have any good or rigorously done research information to answer that. The second thing is, depending on what approach you're using, whether you're using transcranial magnetic stimulation, whether you're using direct cranial electrical stimulation, so low ampage, or whether you're using deep brain stimulation, any of our techniques, there's a lot of spillover or uncertainty in terms of what you're targeting and what you're actually activating or inhibiting. And this comes up particularly with some of the TMS, the transcranial magnetic stimulation, in different styles or shapes of magnetic coils, and questions about how precisely we are triggering a specific area. And at least some of the depression research suggests, the standard right now in clinical practice is just use markers on the surface of the skull to identify where to place the coils. But there's some evidence that if you use functional MRI and actually know when your coil assembly is located in triggering premotor cortex or some specific area, then you have better success rate in treating depression. So we have lots of imprecision with our current methods. With some of them that may matter a lot, with some it may matter less. And it's a good question. I think or hope that we would be moving forward. If nothing, even if the stimulation of an adjacent area didn't produce any effects, that would actually make it a great control or sham use when you're trying to do a formal study of how big an impact you're getting from stimulating prefrontal cortex versus not. So hopefully that covers that one. So Dennis asks, do I plan to upload my interview from the ADHD Business or Entrepreneur Summit, whatever it's called? So I have not been in touch with them. I actually have not seen the video myself. I was busy with the patients when it was actually airing. The recording was airing live. So my thought is I do need to get active in contacting them or seeing if I can just download it myself or at least provide a link to it. If not, it's likely I will wind up sort of re-recording my version of it. And I do have an abbreviated one of the somewhere in the first dozen videos on this channel. And I think they're sort of arranged chronologically. So if you go very back or just put in scheduling, I'd say maybe unfortunately, maybe fortunately, my ideas have not changed hugely since that original video on scheduling. Maybe I say it more articulately and provided more detail, but scheduling, I think, other than sleep, I think is the biggest non-medication tool for helping people with ADHD, and helps people without ADHD as well. So, hi, Max. So Max is sharing his anecdotal experience that the biggest factor for accent in a secondary language is age starting to learn the language. And he doesn't distinguish whether having ADHD or not makes it more likely or not to have an accent. And Dennis is piping up that being a Spanish and English speaker, he's agreeing with Max. I would say I can share my own experience. I was in a public school system in America, which started French instruction in, I think, 4th or 5th grade, which I think is too late. It was 20 minutes once a day, 20 minutes a day, or maybe even 20 minutes just a few times a week. So it was not at all immersion, not at all full force. And I would still rate myself as basically a monolingual person. So I would say I've always spoken slowly. And I think that for me is the biggest factor in challenges in mastering another language. So I did take Latin in high school. I did take French in high school. I did pass the advanced placement tests with the highest scores you can get. I did pass out of college language requirement because of proficiency there. But I've always could write and read. Well, read better than write better than hear better than, probably speaking better than hearing. I think I have a somewhat slower cognitive processing, and particularly hearing or speaking is horrible. So I'll share more, overshare. So I had French, and I had some amount of proficiency in that. I wouldn't call it fluent. But then during medical school, part of my heritage is German, so I was sort of dismayed that neither of my parents spoke a word of anything outside of English, and I didn't want to be that type of American. So I took audited, I think, 3 semesters, sat in on German classes during medical school, which in retrospect, I don't understand how I managed that. And then after 2 years of medical school, spent 4 years in PhD land and did a postdoc in Switzerland at the end of that before jumping back to the last 2 years of medical school. This is a long story. Anyway, spent 6 months in Switzerland, in a German-speaking part of Switzerland, and can remember going to a conference in Lyon in the south of France and trying to use my old French, and I would speak a few words of French, and then unconsciously, because I was focusing on German that time, I would throw in 2 or 3 words of German, and then before I could even stop myself, I would say in English, no, what I was trying to say is this or that. So I had a complete jumbled mess of franglais, German, whatever. Whereas if I just spoke, this was a scientific conference, everyone there had English better than my French or German. I think people appreciated I was trying, but I would have been much clearer if I had just stuck with English instead of trying to speak one or the other. So it was a good example of one language sort of pushing out or making another more difficult or complicated. Anyway, thanks for indulging me. I see there's good questions. I'll try to get to those. So Philip asks, should hypertension be an exclusion criteria for stimulant treatment in ADHD, or could elevated blood pressure itself be a symptom of untreated ADHD that might improve with treatment? So there was a study that came out just this week, so I don't know if you're riffing off of that or this is spontaneous, that was, again, it's sort of strange how some studies attract national media attention. It was proclaiming that all of our ADHD drugs, not just our stimulants, can increase blood pressure. Now, it didn't include guanfacine, which is FDA approved for ADHD and is approved both for ADHD and originally as a blood pressure lowering agent. So this is not applicable to guanfacine or clonidine. But any of our medications that specifically are norepinephrine reuptake inhibitors, there are norepinephrine receptors on small, tiny blood vessels, and tightening of tiny blood vessels is what causes an increase in blood pressure. So it's not surprising that on average, and looking at averages, the average number is pretty small. It's in the range of 3 to 5 points of blood pressure at normal therapeutic doses. Certainly if you go higher, it can be higher. And that's comparable between things like Strattera, duloxetine, Wellbutrin, and so non-stimulants, and amphetamine versus Ritalin products. So there doesn't seem to be a huge advantage just in terms of blood pressure between one group of medications or another. There's a lot of idiosyncratic variations. So one person may have higher blood pressure with Ritalin and not on amphetamines, might on Strattera and not with Wellbutrin. So there can be variability. For other people, they're sensitive to this as a side effect with any of the agents. What else should I say there? Is that the group average is, I think, misleading, and that some of the evidence that breaks it down more clearly into groups of people, and what would correlate with my clinical experience is the majority of people aren't seeing any measurable or detectable increase. It's so small, it's undetectable. But somewhere between 15 to 20% of people are facing a larger 15 to 20 point increase. And so which then may be a clinically significant one. So the other data, we have some data and lots of clinical experience, is that usually standard antidepressant regimens and many people who are only dealing with high blood pressure need more than one agent from more than one class to get good control. And much of figuring out what blood pressure medication is trial and error and guessing. We don't have great predictive markers for demographic features. We have a few that indicate who's going to respond well to what. So often psychiatry is labeled as sort of it's guinea pig trial and error, and the rest of medicine is much more precise and predictable, and partly because it's measurable. But lots of areas of medicine, we don't have a good idea which is going to be the best drug for a person. So usually, if someone's already on antihypertensive agents, that controls or addresses any hypertension, increased blood pressure from the agents. Secondarily, if it doesn't at the dose the person's currently on, almost always a slight increase in their antihypertensive medications does control their blood pressure adequately. And as Philip pointed out, that there's a bidirectional effect here. So absolutely a substantial number of people with ADHD do have sympathetic overdrive or arousal, do have anxiety as well, and that an agent that successfully treats their ADHD symptoms can often decrease blood pressure. I don't know how much objective data we have on that, or looking specifically at anxious or high sympathetic tone people to see if stimulants are decreasing it. But clinically, I can say I know it's there and I've seen it. So Max asks, are forgetting what you're about to say and searching for words common behaviors in ADHD? So I'd say they're fairly common in the general population to begin with, but I would say that most individuals and most clinicians would say, yes, those are even more prevalent among people with ADHD and probably are due at least in part to attentional control and being distracted or pulled off track and not being able to return to where you had been. And the related question is, are there studies showing that these specifically are worse for people with ADHD that are bilingual? So again, that the word finding, there is some clear evidence that finding the word in the right language that you're trying to speak in can be more, certainly being bilingual, at least in the early years of learning a language, or with kids growing up in a bilingual environment where they are immersed in both, that there is a longer search for words. And the thought is that sort of as with aging, there is a longer search for words, and so you have a bigger library to be sorting through. So yes, there's some evidence I'm aware of for the searching for words. Forgetting what you're about to say, I'm not sure as precisely what the data there is. I would not be surprised if it's there as well. So Max is letting me know that he does have an edited version of the scheduling talk on the Entrepreneur Summit, but I probably need to investigate what I need for approval. So thanks, Max, who is, as usual, doing a wonderful job of supporting everything I'm doing here, and is usually a step or two ahead of me in many of these logistical tasks. So Luke is, and unless I know specifically, I'll try to be non-specific with genders. Luke is looking at getting assessed for ADHD. If they are diagnosed, how should they approach meds? Should I suggest something, or is it going to be up to the doctor? What are the best starter meds to consider? So one of the things I didn't remember to do at the disclaimer at the beginning here is that I don't have a doctor-patient relationship with any of you. So the information presented here is general information. It's not specific recommendations. So I'll more describe the process I go. So one is that doctors vary incredibly, even within psychiatry, even those who put down that they have expertise in ADHD. Many are good and adept, and some even who put that down really don't seem to have a clue. And I'll say this and not hopefully sounding pejorative, and one subset of those who advertise expertise in ADHD are really advertising that they themselves have ADHD, which may give them good insights or may actually block insights because ADHD can selectively affect attention. So there's a broad range in doctors or prescribers, and other people can prescribe in many parts of the world. There's a large range in expertise, and separate from expertise, there's a large bias in ways doctors are comfortable working with patients. Particularly doctors older than me have more of a tendency to be paternalistic and grew up in an era where the doctor knows best and tells you what to do. Many younger doctors have more of a collaborative approach. So particularly in America, the AIDS epidemic and how ACT UP advocates taught people to take more charge of their medical care had a sort of immeasurable spillover effect across medicine in general, and a generational effect. So there's lots of factors. So I don't know who your doctor is. What I would say is, when I'm listening, one is I'd sort of review the risks and benefits of medication. And this is grossly oversimplifying, and I do have videos on some of this in detail. I'd say the data is overwhelmingly clear that the single biggest intervention for reducing symptoms are stimulant medications. Not that other things aren't important, particularly sleep, and cognitive behavioral family therapy approaches can be powerfully helpful. So stimulants have the biggest impact, and stimulants compared to non-stimulants there's a bunch of what I would call nuisance side effects. So we were just talking about hypertension. We can talk about overarousal. Any of our drugs can do this. The bad things that stimulants have a risk for are uncommon, but they can be really bad. One is potential for addiction, which is there and real and hard to quantify how big it is, but maybe in the range of 2 to 4%. And the risk for psychosis, which with amphetamine products is probably in the range of 1 out of 500 people. And that is a really horrible, catastrophic, bad side effect. I think there are identifiable risk factors. The two I know of are family history of a psychotic disorder and individual past history of a psychotic episode. So those are risks. There are people who've had psychotic episodes on Prozac or antidepressants, but that rate does not seem appreciably different than what is apparent in the general population, even after the emergence of schizophrenic symptoms, which usually happen in late childhood to early adolescence. So if there are reasons you are particularly worried about psychosis or addiction, then that would steer, for many people, a good first choice would be a non-stimulant. If many people have had individual experiences of borrowing their friends' Adderall or just reporting their own response to caffeine. So I would say when I am evaluating someone, I always try to elicit, and I try to do it in a non-judgmental way so I get real information, is what else have you tried? I'd say lots of people with ADHD have borrowed meds or had, once or twice hide things from friends, family, or others. What have you observed? So your past response to medication, good or bad, is some useful indication. So I do use stimulants a fair amount. I have a separate video as to whether Ritalin is really a stimulant or not. But I think more than some of the ADHD experts, I am more prone to starting with bupropion, Wellbutrin, or Cymbalta, duloxetine, or some other than non-stimulants. I'm not a particular fan of Strattera. It certainly is great for some people. And guanfacine, given that its commonest side effects are sedating, is usually a hard sell as a first agent to get people interested in considering. There's some people who either had experience, and I think the other thing is what people have heard about, what their own biases and concerns are, what they've seen in terms of family members or friends, in terms of both side effects and good effects, are useful information. Maybe more important in depression or anxiety, where expectations, I think, have a larger role than in ADHD in terms of how well a medicine will work. But I think there are real and observable placebo elements to any of our treatments with medications. So I hope that gives an overview to Luke as to, so in terms of how to interact with the doctor themselves. One is, again, and this can backfire in some instances. Some doctors will hear, "Oh my God, you've borrowed in 11th grade Jimmy's Adderall and took a dose of it before you were taking the SATs or something." They'll say, some will think you're a drug abuser. I don't want to give you stimulants. My experience is that's a small number, a minority, and that the more open and direct you can be, the better the working communication relationship. So I would say, to frame it in terms of, I'm interested in trying this because I've heard X, Y, and Z about it. And they may say, well, X and Y are accurate, but the Z is really not something we see associated with it, whether it's good or bad. So hopefully you're promoting a dialogue where you're exchanging information, and the information you know best is what you've experienced in terms of ADHD symptoms in your life. And once you do start a medication, what your experiences, good and bad, are. And it's your job to communicate that to the doctor. And it's the doctor, and again, I'm using doctor abbreviated for all prescribers, the doctor's role to take that information about your specific experience and combine that with what they know about ADHD and what they know about the medication to figure out what will be best moving forward. So Max is forwarding a question on the Reddit channel. So again, a shout out. It's under subreddit Dr. John Kruse. And for some people, that may be a better forum for more back and forth among people, or back and forth with me and back and forth with each other about certain topics. So when Beneficial Elk, which is a name I've seen come up before, when I tried 70 milligrams of Elvance, which is 5-ants lisdexamphetamine, it was too much. So I tried to do a water titration. I mixed the contents with water to try to make the dose 50 milligrams rather than 70. This resulted in a horrible time when I get a new prescription for a 30 milligram dose and took the tablets whole, not mixing any with the water. I felt so much better. Any thoughts why this happened? So again, the lisdexamphetamine is a prodrug, so there is no active drug. It should not be floating in the pill. There should not be any that's created just by dissolving it in water. The enzyme that cleaves the lysine from the dextroamphetamine is almost entirely in red blood cells, or maybe trace amounts elsewhere. So this is a drug that needs to be absorbed into the body, and then once it's in the bloodstream, is activated active dextroamphetamine. My interpretation is that, and I see this a lot, and it's always hard to frame it or word it, is that one is dissolving it in the water, you were exposed to the taste of it. So it's a very different experience. And my guess is that there was substantial sympathetic nervous system activation, that this felt weird, this felt different, and maybe even almost partial panic. And I'd say how I define panic is the brain's making the jump from this is weird, this is weird, this is weird, to, oh my God, this is dangerous. And then you're flooded with even more norepinephrine, and parts of your brain are less activated. Prefrontal cortex functions different. Amygdala activation goes up. So my interpretation, and I don't know if any of this is correct, is that when Beneficial Elk dissolved it. It tasted bad. It tasted weird. It felt alarming. Oh my God, am I doing something dangerous or wrong? And that it was the body's own sympathetic overdrive added to whatever dose of the medication eventually got in, got absorbed, and got cleaved to an active molecule that combined to produce too much norepinephrine availability, too much sympathetic nervous system overdrive. So again, I think it was probably more the taste than the actual chemical availability of more or less dextroamphetamine that is responsible for that experience. And I see this a lot, not just with ADHD medicines, with antidepressants, with all sorts of other things. Yes, there are certainly people who have allergic responses. There are certain people who have uncommon, bad, direct physiologic responses to certain medications. But I think far more often what we are seeing is interoception. So that's our body is constantly scanning everything that's going on, chemical factors, pressure, touch, wind, sound, information. Sound isn't sensory information, interoceptive information, and feeding it through the insula and other parts of the brain to centers that are scanning for, is something different than usual, is something out of place, is something weird. And some people, particularly if you've had panic attacks multiple times, your panic threshold is lower, and it's much easier to make the jump from this is weird, this is different, to this is dangerous. And then you are having real physiologic symptoms. Your heart might be racing, you might feel sweaty, you may feel dizzy, your vision is altered. All those are real, and cognitively you're less able to think. I mean, that's measurably so. So I think that distorts, and I mean, it's easy then for the person to attribute, oh my God, this pill is bad for me, or this pill really had the wrong drug, or pill was laced, or this pill, the company's defrauding and isn't the real thing. And those things may happen some of the time, but I think more often we're triggering panic. So Philip asked, why isn't Adderall approved in Switzerland or most European countries? So one is, I would say, and I'm not completely up on all the laws everywhere. What I would say is it's approved in more countries than it's available. So and I believe I've heard people reporting in Spain, that there are some countries where it's officially there and allowed, but you can't find a single doctor who's willing to prescribe it. So there's availability issues as well as, or willingness to prescribe, as well as what is legally allowed. So in the EU and in the US, it's the FDA that determines whether a drug is approved for a given use. Drugs can certainly be approved for one use and then legally and ethically, I would argue, used for other purposes. So there's drugs like modafinil that were approved for narcolepsy and sleep shift work disorder and obstructive sleep apnea that can be used off-label for ADHD. So the regulatory agencies are trying to ideally combine science with public health concerns or values. So they may determine that at a countrywide level, they believe there is a greater risk from addiction or misuse or abuse than there would be benefit from some individuals with ADHD responding well to this medication. I mean, clearly, drug company lobbying outside of what they officially show in their studies, I think is a factor in different countries. And there can be benevolent angles on that, and there can just be purely greedy, capitalistic, corrupt angles on that. Different countries, again, have had different experiences with different epidemics, different crises, different ways the population has responded to medication. And that there might even be biological differences, but I think cultural differences, I think, should have some role. So we pretend these agencies are working on the science, but there are some factors that science can't answer because they are tied in with our values. And I mean, some of this we saw in discussions about vaccines at a scientific level. Is it absolutely clear that our vaccines for COVID, our vaccines for measles are, one, highly effective in reducing the likelihood someone catches disease, and two, highly successful in reducing the likelihood of dangerous or fatal outcomes? Absolutely. But whether everyone should be mandated, whether just high-risk populations should be mandated, whether high risk is defined by demographics or high risk is defined by prevalence of the drug in a region at a certain time. I think there are legitimate reasons that reasonable people can come to different conclusions on what is the best public health measure, but I think you cannot have any reasonable public health measure that's inconsistent with the science. So if you show repeatedly that, and I know there's some people who have controversy about or feel that there is some conflicting view as to whether ivermectin may have some efficacy, but most of the research I've shown, if you show that drug X really has no benefit, then you cannot have an ethical public health measure that is recommending people take drug X to treat your outbreak. So Rafif, is mentioning that they started forgetting English words they knew when they were focused on medicine and medical English. Yeah, so Max is forwarding that Philip is reporting the same issue in France, that because of conservative governments put the fear of addiction higher than the well-being of patients. So Max asks, what are some of my strategies for people who take 2 long-acting doses, one in the morning and one at noon, so that the dosage doesn't get too strong when the meds cross, but doesn't last too long at night? I don't know that I have one is, the simple strategy is, one, letting people know that this is even a possible option, because often lots of pharmacists are sort of locked in. This is a take early in the morning or first thing in the morning drug. And incomprehensibly to me, some of them don't accept and or encourage or not allow, because I don't know if they have that much permission to ban it, but are flummoxed by having directions. So one is that usually the first dose, the timing there, the importance there is getting it in as soon as possible, because unless you're taking Jornay, which works, you take the night before and has a coating where virtually none is dissolving and entering the body for the first 10 hours. So most people need to get some drug in as soon as possible. One strategy that works for many people is actually setting an alarm an hour or two before you're going to really get up, taking your first pill then, and most people with ADHD can get back to sleep. And then when they do wake up an hour or two later, the drug is working quickly. Other strategies I think are important, because for many people with ADHD, the morning time is their least organized functional time, is having the pill and the water set up by your bedside right there, because some people, well, I'll take it first thing in the morning, and then they're struggling to get their coffee or do X, Y, or Z and don't even remember or realize that they haven't taken their drug for an hour or two. So getting the first dose in, I think, is important. And then I'd say usually, the starting point is taking the 2 together. And then if that isn't optimal in terms of either duration of action or too strong an action at certain parts of the day, then splitting up the dosing. I would usually, I think for most people, taking the second dose within an hour and a half is going to be so hard to distinguish from taking the two together that I would start with at least a 2-hour delay for the second pill. Again, these are general recommendations, not individual specific medical recommendation or general information. I'd say the commonest pattern, and most often I'm probably talking about either Vyvanse or Concerta. So some of this, the recommendations are going to have to do with how long the delivery span covers for each agent. But a fairly common scenario I have is taking the first one early morning and the second one late morning, and usually just before lunchtime. And usually if someone is taking it much later than lunch or during siesta time, I mean, one is so I have a talk on siesta time in this gap. There is a lull in alertness in most humans. It's ruled by our circadian clock in very early afternoon, and it is independent of whether you have a big lunch or meal or not. So many people think, oh, siesta time is just, I've had a lot of food, the blood's going to the digestive system, I can't think clearly. So they've had people, on a hospital gurney with IV nutrients going in 24/7, and there is still a siesta time lull in alertness. So again, usually waiting till lunch or later than lunch results in having too much around at the end of the day and having trouble sleeping, which then compounds ADHD symptoms if you're not getting enough sleep. But some people vary. Again, drugs like bupropion, Wellbutrin, when they first came out, were marketed as a 3 times a day drug with a dose at bedtime, and that's a dose of the acute immediate release. Most people were still able to sleep on that. A substantial minority couldn't. There are some individuals who take a small dose of Ritalin or amphetamine, usually 5 or 10 milligrams at bedtime, just because it helps them contain organized structure, turn off their thoughts, and go to sleep. So there's a lot of individual variation, and listen to your body. What I would say is usually within 2 or 3 days, you should know whether this is a pattern of timing that works for you. So most of the effects of these drugs on ADHD that we're talking, the stimulants and non-stimulants here, are fairly immediate and direct. And yes, there's day-to-day variability in everyone's life, but you should get a pretty clear picture pretty quickly. Rafif asks whether I recommend choosing a specialty as a doctor on medication or without it. So I'd sort of take a step back, and I'd say that, and some of this I was addressed in a related way, in the Huberman way. I mean, one is there's sort of a thought or meme or idea out there, maybe, that certain careers are great for people with ADHD and certain careers are bad ones. So I'd say, most people with ADHD aren't going to thrive on an assembly line where they're screwing in the same bolt each day. But I would argue most normal humans aren't going to thrive there either. I do think that people with ADHD, I think there's evidence clinically and experimentally that the structure around you is more important to those with ADHD because it's harder for them to create that structure themselves. But I would say, there are lots of ways to be an architect. There's lots of ways to be a neurosurgeon. There's lots of ways to be a psychiatrist. There's lots of ways. So even if most people are doing better with a linear, conventional brain in that field, that doesn't preclude it necessarily from you. So I would sort of start with looking at what are your own interests, what are your own strengths, what are your own weaknesses in terms of how does my ADHD influence, in this case, which specialty in medicine feels like a good fit for me, or which other more broadly career fits. And then secondarily, I would assess what about me, how do I function differently on the medication, off the medication? I mean, do I generally have side effects I'm putting up with to get the benefits, or am I pretty free of side effects and it's just all good? And then the issue of whether I take it every day is due to more philosophical issues rather than physiologic, practical issues. And this may seem touchy-feely or less scientific, but I would say, do you like yourself better on your meds or off your meds? And it probably isn't an all better or worse. It's I like this and this, and I don't like this and this. So that's what I would be thinking about rather than sort of a blanket, yes, if you're on medications for ADHD, you definitely should interview and consider and only apply to things while you're doing that. And I'm realizing I've been talking at length on some of these questions, so I only have about 10 minutes left. So Jim Rowe asked, what are some of the most effective, lesser-known strategies you've seen actually help adults with ADHD manage focus, motivation, and follow-through, especially without relying solely on medications? One is I don't know that I have lesser-known strategy. I think lots of the strategies that seem to work are fairly widely talked about. And I would jump back to something that Ed Hallowell, who wrote Driven to Distraction, would say, sort of jumping back to Rafif's question about medical specialty, is it for someone with ADHD, finding a career that's a good fit for you is important. Trying to force yourself to do something that you don't find interesting, or so the starting point is knowing yourself and knowing what you're good at and knowing what you like to do. That's going to set you up on a much greater likelihood for success than trying to force yourself that doesn't fit those parameters. 2 is, I think, the cognitive behavioral strategies, and Mary Solanto's group at, I'm not remembering which New York City hospital, and Stephen Safran's group at Harvard, and some collaborators at, I think, University of Pennsylvania, came up independently with cognitive behavioral therapy approaches for ADHD, and lots of cognitive behavioral approaches are antithetical to ADHD, lots of boring homework, but decluttering your work environment, using a schedule to know what you are doing right now, and knowing that you have had your sleep, your meals, your entertainment, your downtime, your fun time also blocked in, so you're not fretting or worrying, God, I have to do this 6 hours with no break, as you know. And part of using a schedule is, yes, respecting it and using it, but also learning from it. So this doesn't bind you into doing the same thing that doesn't work week after week after week. If it's not working, at least having had it scheduled, you know it's not working, rather than just knowing, I'm not getting this done. What are other little snippets of, I'd say another strategy in terms of time management is thinking about things in terms of expected time of arrival rather than expected time of departure. Knowing when you need to be somewhere means you have to be planning leaving well before that time. That's my best overall answer there. So Marek asks, what do I think about taking stimulants, let's say Ritalin, with days off and days on, like, for example, 4-3? So I do have a talk just on drug holidays. So this is one area, on lots of things, the ADHD field has seemed to be sort of remarkably, the experts consistent or all on the same page. Holidays, there's a little more variability. So one group would say the ADHD is something that affects not just cognition, not just classroom performance or work performance. It affects social interactions. It affects all of your life. If the medicine is helping you be your best self, why would you want to not be your best self on the fun times, the weekends, the times you're trying to organize activities? And I have a saying that if you have ADHD, free time is your enemy. If you have less structure, less support, more options, more fun, higher expectations that you're going to be enjoying yourself, then you're often setting yourself up for disaster if you're not having structure. On the other hand, if you have a partner who's happy to plan your weekends, or you can get enough planning and scheduling and structure done on the days in the middle of the week. So I don't have a blanket. So again, some researchers or some clinics feel, so the other argument for taking it every single day is that forgetfulness is a hallmark of ADHD. And if you're encouraging people, you can take it Monday, Tuesday, Wednesday, Thursday, and you can blow it off on Saturday and Sunday, then what happens on Monday is you've been programming yourself to be forgetful or not remembering it. Yes, you can use pill boxes on days designated or not, but in some ways, we're reinforcing the inconsistency, and being consistently inconsistent as a hallmark of ADHD. So I can see some arguments for taking it consistently, but I can also say, I treat it as a tool. Like, you can even compare it. People use crutches as sort of a pejorative, but if you have a broken leg, crutches are essential and useful and great. But if you're just playing Twister, then using crutches may get in the way and not help. So I would say the strategy that works for an individual, I'd say what's disappointing is that there are numerous claims that rates of addiction, rates of abuse, rates of dependence are going to be lower if you are inconsistent in taking it, if you give yourself a break or holiday. And there's very, very little hard data that document or support that. There's some basic science reasons. Some of that may be true, or tolerance may be lower, but actual real world experience or benefits from an intermittent schedule are meager at best. So Mr. AKA asks whether I have any patients taking atomoxetine, Strattera, along with guanfacine and Tuniv. What's the combined impact on norepinephrine from taking both these drugs? So again, I use Strattera, atomoxetine very little. I certainly have people on conventional stimulants, methylphenidate and amphetamine products and guanfacine. I have people on bupropion and guanfacine. I have people on duloxetine and guanfacine. So, and you ask what's the combined impact on norepinephrine from taking both these drugs. I think sometimes we take our stories about neurotransmitters too literally or too rigidly so when I see someone on both the drugs, what I am seeing is the impact of everything the drug's doing, including their expectations on them. I'm not just seeing the effect of norepinephrine, even though I think, yes, there's some validity to attributing much of what we are seeing from a norepinephrine reuptake inhibitor to norepinephrine. But I'm leery of casting the story that way. I don't know if I was clear on that. What I would say is combining guanfacine with the norepinephrine reuptake action, again, tends to make anxiety less of an issue, agitation less of an issue, overactivation less of an issue. And in many cases, the guanfacine is providing additional benefits beyond what the stimulant or the norepinephrine reuptake inhibitor alone could provide. Rafif mentions that it's harder to tolerate summer since he started ADHD medications. I'm feeling overheated, so I do have a video just on temperature and ADHD. I didn't talk a lot about the medications per se, but some aspects of our autonomic nervous system that control sweating, that control blood flow to the skin. Again, blood flow, tiny smooth muscle cells in the walls of arteries are what affect constriction and and expansion of arteries and blood flow and are affected by ADHD medications. So heat dissipation can be harder for some people on a stimulant medication. Luke said, and I'm almost worried that someone's trolling me when I see Jordan Peterson, said that most of the time ADHD is being misdiagnosed to kids and that they are severely lacking play in school, which results in them becoming hyperactive. He said they need to be allowed to play way, way more instead of being medicated in most cases. What are your thoughts on this? And thank you. They're saying they're not trying to be provocative or causing drama. So I think he's both right and wrong. So I think there's, particularly in American education, there's been an emphasis, and a lot of it came into play under George Bush and having standardized education norms so that there became much more teaching to the test and measuring performance of schools, teachers on that merit. So this is a really complicated, messy issue. I think it makes sense to have some sort of national curriculum and standards. I don't think in a country it makes sense to be teaching in some areas that it's okay to identify what your own gender is and define it for yourself rather than having others do it, and have other communities saying you should follow the 10 Commandments and Judeo-Christian principles, and that should be taught in schools. So I think for a nation, it makes sense to have some national standards and curricula. This is getting maybe too far into politics. I think part of what schools should be teaching isn't just content and information, but how to take care of your body, how to take care of your brain, how to be responsible, kind people. And there's overwhelming evidence, which has been increasingly ignored, that training people to be nice and respectful probably has as much to do with long-term success as educational attainment, and probably much better impact for society. So yes, things like arts, music, educate, or exercise are important and neglected and absolutely should be a bigger part. On the other hand, the claim that ADHD is being wildly overdiagnosed in kids or others, particularly in adults, I still see way more adults who have clear, robust symptoms of ADHD going back over years and decades that have caused serious problems in their work, in their school, in their relationships, who were not diagnosed, sometimes were misdiagnosed with other mental health conditions. So clinically, what I see, and I am not a child psychiatrist, there's a misstatement in the introduction in the Huberman interview, so I'm not a child psychiatrist. So I have less to say about children. And clearly in the US, there are lots of regional differences and regional racial differences. So I think, yes, in some jurisdictions or areas, there is overdiagnosis. I'm not saying it doesn't exist, but I'd say more often it's being undertreated or under-identified. Whether physical activity itself both has long-term benefits and short, immediate, acute benefits. So I think there's a very large kernel of truth in what Peterson is saying about the benefits of exercise. Where I would disagree is I don't know that that means people are being misdiagnosed as having ADHD. So thanks, Max, he's included links to the video on ADHD and global warming, which talks about temperature. Yeah, so I will not be, I think I've said enough of what I need or want to say about Jordan Peterson, and not giving him more attention is more than most of his ideas merit. That's where I will end it. So thanks for asking wonderful questions. Thanks for posing them on Reddit and ahead of time before I got started today. Thanks for listening and watching to the videos. Be sure to share them with not just friends or others who you think might have ADHD, or family members who don't really get ADHD yet, but also your there's a large number of clinicians, fellow psychiatrists, other therapists who are finding value in watching these videos. So thanks for being here, and I'll try to remember to smile more and speak directly into the microphone. So stay healthy, stay happy. I'll be back next week, same time. And I'm having trouble turning things off.